Hello, I'm Lizbeth Vitruba, the Chief Clinical Officer for AvaSure, and I just have to say it's an exciting time to be a nurse. We're amid a transformation right now, and nurses are taking a lead in a way that really I've never seen before in my 30 plus years in healthcare. I'm sure a lot of us have heard that old adage that it takes 17 years to apply research to practice, and I want to believe that this evolution is happening a lot faster than that. But with that speed comes some challenges, and that's kind of what we're here to talk about today. Implementing a virtual care pilot is one thing, but to transform the care delivery model in hospitals, hospitals must define a long-term strategy and deeply understand the clinical workflows and have the leadership that's required to not only implement but sustain real change and get to lasting results. So that's a pretty big challenge. And when we thought about sharing this inpatient virtual care maturity model, which is just kind of a framework for all that, we knew we needed someone to help us present who had been involved in the development of this model, who is a phenomenal communicator, and who has relevant, broad professional experience. And so that person is Claire Zangerly. And her background is perfectly suited to help us translate application of this framework. So very excited to have you here, Claire. I'm just going to embarrass you just a tiny bit because your background is just like it's as if it's tailor-made. So Claire recently served as the System Chief Nurse Executive and Chair of the Nursing Institute at Allegheny Health Network in Pittsburgh. In her role, she was responsible for shaping and implementing nursing strategy throughout the integrated health system, covering Western Pennsylvania, parts of Ohio, New York, West Virginia, with like 6,000 nurses under her leadership. And it was acute and ambulatory responsibility and collaborating with AHN home and hospice services. But she's also, in addition to being a system CNE, she's also been a CEO of Visiting Nursing Association in Ohio, the largest home care and hospice organization in that state. And prior to that, had various roles at the Cleveland Clinic, including Chief Nursing Officer and Chair of the Nursing Institute and Director of Quality and Accreditation. So if you're paying attention, you can kind of see that there's different, there's different perspectives. Being a single hospital CNO, being a system CNO, having a CEO responsibility, as well as kind of deep knowledge across the continuum of care, both acute and all the way to hospice. So that broader picture. Then recently, she's up-leveled her perspective to really areas of national influence. So she's consulting with many health systems now in the practice of nursing leadership and healthcare operations with her company, CMZ Strategies. And then she serves on several key boards. And you could be a poster child for the coalition, Nurses on Boards Coalition. So I love Nurses on Boards Coalition, by the way. So she's served as a trustee on the American Hospital Association. She's on the board of directors for American Organization for Nursing Leadership, which is where we get to work together a lot. She's on editorial boards for the Nursing Administration Quarterly and Nursing Management, and the very prestigious AvaSure Chief Nurse Executive Advisory Board. We love having you on our board. And naturally, after all this, she is recently named as Modern Healthcare Top Women Leaders in Healthcare. So, but if you really want to see Claire's face laid up, talk about yoga. Just so that's so welcome, Claire. Thanks for being here today.
Thank you. It's great to be here. Appreciate it.
Yeah. So before we introduce this model, which is a framework that people can, just use, take parts from it, meld it with the other framework that they might have at their health system, let's talk about why there's a need for a maturity model, specifically for inpatient virtual care.
That is such a great question. And I love the phrase maturity model because it explains things so much. And I think it's important to adapt to vernacular like that. There's been so much discussion on virtual nursing and that virtual nursing is the answer to workforce shortage. And, we see it in print, we hear it discussed on podcasts and in presentations and things like that. And it's a lot of pressure for nurse leaders when their CEO comes to them and says, hey, I heard this about virtual nursing, or I think virtual nursing can fix workforce for us. Can you implement that for us right quick?
Sure.
It's a lot of pressure. And it doesn't just happen overnight. It comes with a maturity model. And we all know that having a strategy is important, no matter the elements of the strategy. But that's what that maturity model is. However, it's more of a roadmap for what you're trying to solve, and it's how to get there. It's the solution, it's the tactics, it's the goals, and it's dynamic. That's what a maturity model is. It's not something you write and say, okay, for 2024 to 26, this is what we're going to do. A maturity model evolves. It's an evolution. And it turns it helps us as nurse leaders be not just transactional, be
Yeah.
transformational as well. And that's so important in the work that we do.
I love that, not just transactional, but transformational. Absolutely.
Mhm.
So the way we kind of approach this, we saw a need for this, and I think it kind of came, I would say, about 18 months ago when we had a dialogue with our chief nurse executive advisory board when we spent a few days out in Arizona last March. And our Claire's one of the members, and we have several system CNEs, and then it's about 10 nursing leaders, and you can see who they are on AvaSure.com, but system leaders, but then some individual hospital CNOs, and an industry advisor, coach, and even a recently retired system CNE who can be very free with her feedback, which is awesome. Um, and then different regions as well. So we're kind of getting input from for-profit and not-for-profit health systems, and then we kind of unveiled something last March. Then we iterated and iterated. We had another virtual meeting last fall, and then we kind of had a lot of conversations with our customers, and got further feedback that it needed to be kind of a bigger picture, and it's not, like you said, just a transactional, do A, B, C, and D. And then we also have gotten feedback from some of our CIO partners. And so we're really, it's been shaped, it's been iterative, and so we're kind of excited to share it today. But before we do, let's do a polling question. And we have a lot of registrants from many different health systems. So let's see where you are at, and has your organization implemented virtual care for inpatient acute care? And where are you? If it's a no, why not? There's a couple options there. Budgeting constraints for sure. Lack of confidence in, like, is there really an ROI there? And if you're in the consideration or development of strategy, did you run a pilot and then it kind of stalled? So it was just a pilot, an eternal pilot? Or is it you're currently piloting, just starting piloting, and are planning to move from there? Or do you have it implemented in some departments, or do you have virtual care in most, if not every department? And I see the polling is happening, but I have the privilege, I've been able to attend several conferences, and that's as part of my role. I get the luxury of attending probably a lot more conferences than I did when I was working for a health system. And there are often audience polls, and I've been watching those audience polls and taking pictures with my cell phone of those audience polls from AONL, ATA. I was at a recent CNIO summit in Orlando, and I really see a progression over the last few years from, first of all, there's a very few no's, like we're not doing it. And piloting has grown quite a bit. So let's see if we're ready to share. Okay, so it's ended, and it will be shared. I can see it. Claire, can you see the results of the poll? Okay, so um, really nice even split after we get away from no. And we're seeing a lot in kind of that, the most in that implementation or development strategy. A few currently piloting, and then a good portion of our members are really deep into virtual care. And so that's really phenomenal. Thank you for responding. Um, so let's just kind of walk through the virtual care maturity model that can be used just to be more strategic and kind of think, have we thought of everything as you're on the road to implementing inpatient virtual care? So kind of starting with the bottom, that traditional care delivery, and I think very few are here, even in the inpatient side, where there are, no virtual care workflows. I think almost everybody has gotten to that early adoption stage where you're at least experimenting with sporadic virtual care pilots, or kind of chosen a low-hanging fruit, one specific implementation, if that's like kind of virtual nursing for discharges, or so you can get people cleared out and like get your ED holding area unstopped. So there's a need, and then there's a specific pilot for that, or virtual sitting if there's high fall rates and or high sitter utilization and virtual sitting is underway. I was at a great summit, a virtual nursing summit in Washington, D.C. last fall, and that was sponsored by the ATA, American Telemedicine Association. And there was a lot of conversation about not even using the word pilot. And people were like, no, we hate saying pilots because that kind of implies maybe it'll work, maybe it won't, and it can stop. It was to the point that somebody had to say, one of the speakers said, I just want you to know, I don't hate pilots. Like, I married a pilot, and pilots are okay. I love pilots, but let's call this a demonstration project. And then getting into that kind of strategic advancement where you may be piloting or doing a proof of concept, but you're doing that with a more strategic plan in the back of your mind. Like, here's where we want to get, but here's where we're going to start. Sort of establishing infrastructure in advance, for example, maybe doing admission and discharge, and maybe your virtual nurse is only during certain hours of the day, but you're making decisions with where you want to get. And on that 2 and 3 side, on the technology underpinning, that may look like mobile devices and getting ready for an every room kind of solution as you move into 4, where you're increasing the scale of patients monitored and integrating technology, implementing consults with other, it's not just virtual nursing. There's just so many opportunities with pharmacy, physician specialists, case managers, respiratory therapy. And you're starting to need a device in every room because that workflow gets in the way of having to, move devices around. And then ultimately this nirvana where we all want to get eventually, where the smart room, the technology is so seamless that the caregivers barely notice it. And, maybe natural language processing is happening, and things are getting dictated through AI in the patient room, and all the integrations are seamless, and you get back to traditional delivery of care where you can just be so present with your patient. So ultimately, technology that gets you back to old-fashioned patient care is my dream. So, Claire, where do you think most organizations are now on this framework? I can't hear Claire's audio. But well, we at our Chief Nurse Advisory Board meeting, we did take like a deeper dive drill of this model and kind of had this conversation. And we had placemats. This is a much more detailed version of kind of definitions and different rows beneath all of this layering. And we kind of did see the bulk of where we're at today is sort of that area from early exploration to measured improvement with an eye to getting to that, perfect smart room integrated world that we would all love to see. And I think that the technology underpinning is the support of it, but not the leading edge of that. Um, and then I would say also from the polls that I have seen and the polls that we had, it's kind of in that early adoption versus strategic advancement and measured improvement areas. I think there was one thing that I think I could talk about while we're waiting Claire to join, and that is kind of how does artificial intelligence impact an inpatient virtual care maturity model? And that is just one piece of the technology, but it's such an important one, and it's being discussed that we need to really have good answers and good understanding of how does that support inpatient virtual care, and what role does it play, and how can it be responsibly and ethically used, and where AI can support. It can start with assisting, and then it can move into augmenting, and then it could also automate. And those are really levels of how AI can impact patient care and how it can be leveraged. And I think there are some fears if you only see it not on a spectrum, but if you only see it on automating. And so automating would be where you're replacing that person, and where we see that in healthcare really is more on back office and billing and some of that not direct patient care. So AvaSure's kind of stance on AI and how it supports a virtual care maturity model is really focused on assist and maybe augment. So for example, assisting would be on our the recognition that a patient is about to fall, prediction of fall, where it alerts the virtualist. If that is a virtual safety attendant, they get an alert, this patient might fall, and it's assisting them to focus on that patient. Or we're using it as well. We're going to be using it for recognizing potential violence in a patient room. So patients escalating, they're using certain keywords that we've learned from large language models that could potentially lead to violence, and that assists and alerts the virtual side. And then augment would be at the point where that is so seamless that they're able to manage more patients. Or a nurse is able to use documentation, or a physician able to use a documentation that they're able to augment their practice. So I think an important baseline for using AI responsibly and ethically is like understanding this use case is best used with this level of AI. So I knew that that was that question I was going to address. So I thought I would take that one up early while we're working on your audio, Claire. I think another thing we were going to talk about on the maturity model is how does it facilitate and help align with IT, with the discussion with IT teams. And so when we had some of our CIO advisors give us a little bit feedback on the maturity model, they talked about, I love this quote from one of our CIO advisors. He said, I see my job as 95% change management and 5% technology. And I heard another IT expert say that these types of transformations need to be clinically led and IT enabled. So I think really way up front, instead of just ad hoc, we're looking to solve this one problem with this one solution, being more strategic, looking at your long-term plan, bringing in IT, and really making the decision that helps fit the long-term strategy. So, and we would love to have further deeper conversations with our customers or those that are on planning that could really walk through not only what stage are we, what stage do we want to be, and really looking into our more detailed approach, which what is the problem to be solved, and what is the leadership and governance process under that? What are the metrics and outcomes we're aiming for at each stage? And almost lastly, then if we know all that, then we know the technology infrastructure that needs to support. So, Claire, welcome back.
Can you hear me now?
Yes.
Oh, good. I no
Awesome.
idea, no idea what happened, but thank you for punting. Okay.
Yeah, yeah, no problem. But I know one of the things that we really wanted to talk about was what are the what do you think are the long-term benefits of a maturity model for virtual care using a framework versus that ad hoc approach?
I think that it's really important to look at the maturity model in terms of a long game. It really leads to greater success if you're looking at the long game instead of the immediate satisfaction.
Hmm.
It's not like you're delaying gratification, but make sure that you understand that this is something that you have to be consistent with. Patience is key. And even though it's super hard to be patient in this current healthcare landscape, it's very important because uh, implementing a well thought out plan is going to lead to a lot less waste and a lot less regret, like, oh, why did I choose that instead of the other? It's going to be a better return on the investment with and having that patience. And in the end, you'll have a maturity model that can evolve over time, and it will stand the test of time, even with barriers and headwinds, because we're all facing those barriers and headwinds. And if we have a maturity model that is not a flash in the pan, not something that you just want to get done quickly, then those benefits will certainly pay off. And I think when I came off the sound there, you were asking me where most
Oh yeah,
hospitals fall on the
yeah.
maturity model. And in my experience, most hospitals and health systems fall on this model in two ways. They are either too tentative or they're
Mm.
way too aggressive. There really needs to be that Goldilocks thing in the middle. That's very important. Because if you're too tentative, you really don't get the full experience of launching a maturity model. But if you're too aggressive, you're going to set your expectations way too high, and you may get disappointed, and you may invest so much and get little in return. So there is a sweet spot of that investment in the maturity model. And going into that with eyes wide open is really, I think, going to be a success.
I That's great. We didn't even talk about that before in our planning call, but I love the Goldilocks approach to it. Yeah, making sure that what you are investing in will give you a return, but don't be afraid to kind of just do it and get started. Yeah, that's
Yeah.
amazing. Um, and then, what do you think are some common mistakes hospitals might encounter when implementing virtual care, or
You know,
pitfalls have you seen?
yeah, I think it's the same thing. For example, it's the same mistake you make when you go to an all you can eat buffet. You put way too much on your plate and you regret that. Because the pandemic brought us so many great options in virtual care that we were ready for. We were like, oh, we need this, we need this. But it's so difficult to decide what's best for us as an individual organization. And not every solution is the solution we need.
Yeah,
So being very intentional about the solution, vetting all the aspects of the solution, and determining what you need. The first question you ask yourself is, what's the problem I'm trying to solve for? Then work backwards from that. That's a good place to start. And I like to quote one of my favorite people, Eminem, and he's like, "You've only got one shot. Do not miss your chance." And you know what? Your CFO will tell you that.
Yeah.
Okay, if I agree to pay for this, you've got this one shot. In the case of virtual care, you've got to take that shot in what works for your organization, your patient population, and honestly, your caregivers. That is
Yeah.
huge. You have to make sure that your caregivers are engaged in this as well, because they're going to be the deliverers of this virtual solution.
Yeah, and you made me think of an example, and I think there is a publication bias where what gets publicized, whether it's in Becker's or in a reputable peer-reviewed journal, is success. And not everybody publishes what was amiss. But I will say there was a very good article that was a kind of a rethink, and that was from Mayo Clinic. And they were very brave to talk about what they started with and then how they needed to kind of rethink. And that's exactly what you were talking about, that pitfall. Who was on their planning committee for virtual nursing was pretty focused on leadership, administrative nurses,
Mhm.
and their top priority for implementing virtual nursing was adherence to quality bundles and then mentoring newer nurses, and then last, only when we have time, when those other things are done, we will maybe assist with documentation on admission and discharge. And then they did a survey of the bedside nurses. What do you like or dislike about virtual nursing? And it was kind of reversed. The bedside nurses
Mm.
said, we really need and we really appreciate help with documentation, admission, and discharge. So they really did, and they presented at the ATA Summit in DC. Like that was their phase one, and then their phase two shifted more over to that documentation support, because if their target is nurse retention and nurse satisfaction, um, and that's what I've seen also in virtual sitting, is like we want to decrease sitter usage and we're aiming at this, but then they implement virtual sitting and they don't decrease bedside sitters, they do sitter creep and they just monitor more patients, and then they say, but we decreased falls, but we were aiming for
Yeah.
this target, but you hit that target, which is great, but like you might get a little pushback from your CFO on something like that. So
Yeah, I tell
exactly.
you, you really can't go wrong engaging the caregivers. And
Yeah.
once you do it once and demonstrate that you have success by getting their voice in there, now there's going to be decisions that you have to make that maybe aren't that popular with the caregivers because of different things, but just tell them this is why. And I
Yeah.
tell you, once they help with a positive solution,
Yeah.
then you have just established um, a really great process going forward. That's for sure. And
Yeah.
that's what change management is. You know,
Yeah, and that gets back to your patient's concept, because that may take slightly longer on the implementation side. So, yeah, let's talk a little bit about change management. While you were logging in and out, I was sharing that one of our CIO advisors said that he feels like 95% of his job is change management. And from
yeah.
your perspective, which I talked about in your introduction, you have a lot of different perspectives. How do you think change management is key in adopting virtual care, and what
Well,
strategies are best used?
yeah. Well, you have to think about where virtual care is truly implemented, and that's at the point of care.
Yeah.
And think about who sets caregivers up for success at the point of care, and that's nurse leaders. And if you think about what it takes to introducing something new to caregivers to deliver patients, think about the process that we've been taught since we were in nursing school: structure, process to achieve excellent outcomes. It's so simple that it makes sense, and you think, why don't I do this more? But I think the foundation of all that is change management is you identify that problem and what you're trying to solve, you define the solution to the problem, and then you have to create this followership to make that solution happen. So everybody has to be rowing in the same way. But, work with the staff to show them that their day to day may change with this new solution, but it's going to be the key to success. And that in and of itself is change management and how you can make that happen. But there are some really critical leadership qualities that you need to drive specifically virtual care transformation. And I think, again, it's that followership, because you have different generations of nurses who are, they're either Gordy go hard into this virtual world, or they're like, don't even give me that fancy little piece of equipment. I am not interested because it takes me away from my patients. Whereas it's just really the opposite, because it gives you more time with your patients, because it's reduced your workload by taking out the non-direct care tasks that have become so burdensome to all nurses and to all nurse leaders. And then make sure you're listening to those end users. And in this case, the end users are those deliverers of virtual care. What's working? What's not working? And then being nimble in the execution. If you're not nimble to be able to, go around the corner instead of, straight down the street, then you're never going to get that solution, because you're going to have to tweak no matter what. And if you're rigid, then it's not going to happen. So being nimble and intentional is important. And then, honestly, I think this is very important. And maybe this is because I'm right in the middle of yoga teacher training. Give yourself some grace on execution, because things aren't always going to go super smooth. There's going to be bumps. So don't beat yourself up over the bumps. And bumps like you just described that Mayo had and shared, bumps can be good, because bumps can take you to where you need to go. And I think that's really important. And as nurse leaders, those are hard things to do. You always want it to be perfect, but give yourself some grace, because it's not going to be perfect all
the time. And you've done some work with care model design, and you mentioned leaders, and I think that's a big challenge, is the nurse managers. Their scope of responsibility is so large now. So do you have any, I'm going a little off script, do you have any words of advice? I think that's a real issue, is who's going to be responsible, is kind of gets down to that nurse manager and the clinical nurses. How can we tackle that, knowing how much responsibility they have?
Well, we know where transformation in healthcare is happening, and that is on every single nursing unit, every single care delivery point. That's where transformation is happening. So nurse leaders are responsible for that transformation, but like I said earlier, they're also responsible for all those transactions. So nurse leaders need the support to be able to do those things. And where do we do pilots or demonstration projects? Right at the point of care. Yes. So we have to be extremely careful about how many of those demonstration projects, or how many, hey, let's try this projects, we throw onto the nurse leaders. We have to close the loop on things. We have to make sure that when we're doing something, that we don't start something before we finish it. It's sort of like having 6 books stacked on your bedside table, like, okay, I want to start this book. Yeah, I want to start this book before I finish this book. You need to close the loop, because truly our brains can only handle one thing at a time to be focused on, to be effective. You want to be deep and wide. You don't want to be shallow and wide. You want to be able to finish things at 100% as opposed to 60%. So I think as nurse leaders, we have to take that into consideration, because I can tell you on our longitudinal study that we've done with AONL, on a lot of other studies on our nurse leaders, they're basically saying, I can't do this anymore, because you're asking me to do more and more with less and less, and you're telling me how great this is going to be, yet it makes it harder. So we have to be intentional in giving them enough rope so that they can be creative, not so much rope that they're just going to be tangled up.
Oh, that's another great analogy. I like the buffet. I like the getting tangled up in a rope. I love the too many books. That hits a little too close to home.
Yeah,
And I
it's
was just
true
going to
though.
encourage. We've got a phenomenal list of people who registered who are in the like midst of this. So feel free to not put questions but comments about how you're doing this. And somebody already did, and that's Elizabeth Gunn. So she is a chief nurse at Baptist Health in Orlando, and she will be doing a webinar on AI with us next week, I think, or no, in July, sorry. But she said, and this is a really great feedback on this conversation topic we're having, when assessing that more time is going to be available, let's see, when assessing that more time is going to be available with patients, you have to first measure how much real time is dedicated to the tasks and actions in the current state. For example, we believe teaching for certain disease states will free up an hour a day for the average nurse to do other direct care things. But in current state, they're only using 20 minutes a day for that teaching. And changing will absolutely increase the amount of time being spent on teaching to the patients, a positive outcome. But the nurses won't appreciate the transfer of time expected. So I think that's like, oh, that's a perfect example. Like in your
Yeah.
ivory tower, you could say ideally patients need, an hour of teaching. So we're going to do this and we're going to pull an hour off the bedside. But current state, they're really being forced to try to squeeze it into 20 minutes. So the virtual nurse is improving quality, but be realistic on your expectations. So that's a great example, and I would be happy to get more thoughts typed into the comments. So thank you for that, Elizabeth. Um, and then I think we heard about sustainment as well. So there's a sustainment planning goes right along with the change management. Um, I'm going to throw another one at you, Claire. What are the critical leadership qualities needed to drive virtual care transformation?
Again, like I said, I think you have to create this followership. You have to be a generous listener, um, and being a generous listener means that you've got to listen to the people who are delivering the care, because you as a nurse leader have bought into this model, have bought into maybe a product or something like that, or are considering buying into this product. But you really need to generously listen to your teams and say, what problems do you have? Is it way too many clicks on your electronic medical record? Is that what's giving you the biggest frustration? When you go home at night, what are you most thinking about that you didn't get done, and how can we help you do that? So listening for sure, because they're the end users. And just in making sure, I think a good quality is being flexible and reapproach. You don't have to throw the baby out with the bathwater, but maybe there is a way that you can reapproach what you currently have and tweak it so where it meets your needs. And that again is just being nimble in your execution.
Mm-hmm. That generous listening and that kind of slowing down is something I'm personally working on, and maybe I need to do a little more yoga. But just being, I think just
It's
like
hard.
honestly, being self-aware when I am starting to be like, this meeting is only an hour and we need to cut to the chase, and all of a sudden I'm not listening. So that's a really good reminder to like think about generous listening, take a deep breath,
Hmm.
because we definitely need to hear. And then I love that flexible reapproach. And I talked to a system CMO of a for-profit health system, and he talked about be rigidly flexible. So when they're at a system
Mm.
level, they need to have structure and need in order for something to be kind of replicated with efficiency and with some standards across their health system. Um, and so there's some rigidity, but having the flexibility in there too, knowing that a health a hospital in one state is going to have a different population challenges than another, and care challenges and staffing challenges, like on virtual nursing. And if you're redesigning the whole co-caring model, um, do you use LPNs to assist, or is it certified nursing assistants that are assisting that bedside kind of care transformation? And that really depends a lot on your geographic location. And we had I think, a pretty interesting conversation about LPNs as well. And I don't know if you want to talk a little bit about that co-caring model, when you're, and that's kind of, I think, maybe on a stage 4 aspiration for virtual nursing, that you're not just doing admission and discharge, but you really into the 24/7 entire model, and that virtual nurse is just part of the care team. Often you have to redesign the bedside. So what are you hearing about co-caring and in using different models, including LPNs, Claire, at the bedside for that?
Well, co-caring is a great model, and it's actually the more mature. It's almost, you talked about sustainability.
Yeah,
So this is where you walk before you run, and
yeah,
you evolve into this co-caring model to where it's not just compartmentalized to
right.
certain aspects of care. It If you look at care as a continuum, no matter where you are, this takes you through all the aspects of care at the bedside. And it almost feels like you have a partner in that care,
Yeah,
and that partner has helped taking off some of the heavy burden that has been put on, so that you're in person, and then you have that virtual partner to work with you to take care of the patient. Now, it's going to take a lot to explain this to our finance colleagues so that they don't think that, we're spending too much money on this. But in essence, if we explain this entire process to our finance colleagues as it is, then they're going to see, okay, this is number one, our retention and our attraction will improve
hmm,
significantly, and quality of care will go up, and access will improve, and all of those have, you can monetize all of that, which is really what finance cares about, is monetizing that. And we know what we care about. We care about both, because we want to make sure that we're being good stewards of our resources, and we want to make sure that our patients are getting good care, and that they have access to this care. So I think that the co-caring model is something that will definitely even evolve more over time. People will adopt it, and they'll adopt it to what their organization wants.
exactly.
And
Yeah,
then and then inviting LPNs back into the hospitals. I am a huge proponent of that, and I think if you Google LPNs and Claire Zangerly, you'll see a lot of information about that, because the
yeah,
organization where I was before, I really pushed that. But of course, I was in a region where we had access to hire LPNs, and not everybody does. Not everybody has LPN schools anymore. We collaborated with high schools. If you're in VOTEC in the high school and wanted to be a nurse but couldn't go to nursing school afterwards, after high school, we started you as an LPN in high school and LPN school in your VOTEC program, and then you were right into that LPN world. And you know what? We had to teach the scope of care, the scope of practice for LPNs to our RNs and to our physicians. We
yeah,
invited them back in, not to the detriment um, of taking them out of post-acute care, but they became part of that virtual model. They became part of the care model. So there's all kinds of opportunities, and I think that the more flexible we are, and because how many people have said, I am not hiring anything but a BSN because Magnet tells me I have
yeah.
to. You
Oh,
can't
and that's
do that
that's a
anymore.
misunderstanding. Yeah, yeah,
Yeah.
yeah. And so I
You know
think
what?
that's,
As long as, yeah,
I
as
think
long as
that,
you hit your numbers, and
yeah,
as long as you have that, you're okay. And then anything you do around that is just fine. And the
yeah,
commission says that. And and I think there's going to be a lot of dialogue around that because workforce is changing. And we need more diversity in our nursing workforce. And some of the ways to introduce diversity into our nursing workforce is to allow these different approaches as long as we keep our finger on the pulse of the quality. And I think I no doubt believe we can do that. And we can even do that through some of our virtual care models.
And I think this is a perfect illustration of how complex implementing inpatient virtual care is. And
Mm-hmm.
if you really start out thinking on that end goal in mind, then you realize, that whole leadership framework and I like spreadsheets, so I'm thinking in columns and rows. So the columns are
Yeah.
the stages of where you are, where you want to be. And one of the very important rows that goes across all the columns is the governance in the leadership. And you can't have that conversation without your partners from talent and your partners from
Yeah.
finance. So it's not just, okay, the CNO and the CIO are going to forge, their whole strategy for inpatient virtual care. There's governance that goes way beyond that. So thank you for talking about that. I know that you've done some amazing work with LPNs and bringing in, I love that, from the high schools.
Mm-hmm.
But that was a great way to kind of illustrate how to use the maturity model in the framework to have the
Yeah.
long-term plan in play. So, and then lastly, I'll just ask you if you have anything to add. While you were off on audio, I was talking a little bit about IT collaboration. But do you have successful examples of collaboration between clinical and IT, or pearls of how to foster that?
Yeah. I mean, I was kind of hung up on the whole, well, if I have a nursing informaticist, this nursing informaticist has to be in nursing and report to me. I
Ah,
kind of got over that.
interesting.
I got,
Okay.
yeah, I got over that. And that was okay because you know what? As long as I have that collaboration, and you know what? If they want the nursing informaticist in IT, knock yourself out. That's fine. But this is a nurse and and has nursing practice. And I don't know anything about nursing informatics. Then you know about informatics. I know about nursing. So let's collaborate. So I always used our nursing informaticists as the glue between nursing and IT, and I supported them from a nursing perspective, IT supported them from an IT perspective, and they became the sort of the monkey in the middle that we got to hang on to and forge a better relationship.
Mm-hmm.
And honestly, I got over the reporting piece of it,
Yeah.
and then in another organization that I consulted in, the IT people were like, we're scared of nurses. We don't want them in IT. You keep them, and then we'll work together. So whatever works for your organization, just go with it and don't fight it as long as you have that partnership with your IT leader and you guys show up together. You show up and make sure that you're able to deliver that message together.
Um, that's great. I love that. Like, I can think the underlying advice there is like, um, don't waste energy on turf wars.
Yeah,
And
that's
just
right. That's
like
right.
whatever works, and really the goal is the outcome. So
That's right.
that's great.
That's
That's
right.
good advice.
Yeah,
Um,
yeah.
all right, so I wanted to make sure we had some time for questions, and let's see, what are some that we got? I think there were a couple questions that I could maybe mold together. How can leaders measure the effectiveness of the virtual care programs? And then kind of what are the ROI implications of implementing a virtual care program? So yeah, measure, and then you're often measuring finance. So do you have any thoughts on where to start with that?
Well, I think it's important to be knowledgeable, and anticipate the questions that you're going to get,
Hmm.
and maybe do, of course, do as much research as you can. Anticipate the questions that you're going to get from your finance partners and from, any administrative partners in this, because, and think like they think.
Mm.
They don't think, it's not that they don't think about patient care and quality first, but they think about how to pay for patient care and
Yeah.
quality
Yeah.
first.
Yeah.
So, and that's okay, because that's their job. So maybe think a little bit like them and back into how that can happen and can be realized, while
Hmm.
also implementing something that is going to bring better quality and safety and care to your patient population.
And I'm going to paraphrase Sylvain Trepanier a little bit. He's the system CNO for Providence, and he is one of our advisors on our advisory board as well. And he says something like, we have a duty to not design care models that cost more than what we are doing
Yeah,
now. We
yeah.
just can't do that. But I think we have to talk about how we're measuring the cost and kind of get away
Hmm.
from the hours for patient day as the only way
Oh,
to
yeah.
measure the cost of care. What's the total cost? Because an hour of time from a certified nursing assistant versus a BSN is going to
Hmm.
cost. If everybody's working at their top of their license and skills, you can maybe offset, but that's a big change that is, strategic long-term change.
Right.
So um, great. And so that's what I think, just from my perspective of working with 1,200 hospitals and all at various stages, many, and just because of our history from 15 years of starting 15 years ago with virtual sitting, that's really a great place to start and have an easy ROI where you really are decreasing the ratio of a sitter from 1 to 1 to 12 or 1 to 16. And that can be like an underpinning and can financially support the next level. And then the quality metrics, and then, the getting down to like what Elizabeth put in the chat, are we talking about 20 minutes or are we talking about 60 minutes that we're taking off?
Right.
So those are the things that you drill down as you're getting even more and more sophisticated on your inpatient virtual
Yeah.
care program.
And I
So,
think as a
mhm.
nurse leader, my biggest piece of advice is don't ever underestimate the power of an ROI. If
Mm.
you can become well versed, make it your little hobby, become well versed on how to create an ROI, whether it's your elevator speech, whether it's numbers, whatever it is. That's the language that's going to help you get the resources you need. At AONL, the Workforce Committee, we're creating a span of control ROI tool, so that so that
Ooh.
members so that members can use that ROI tool to plug in everything about their unit. Do I have administrative help? How many beds do I have? Blah blah blah, and then it's kind of spits out through this Excel formula, like, my nurse leaders are, span of control should be this to be able to get this. And it's very simple, it's rudimentary, but the more well versed you become on ROI, the better you're going to be able to get the resources that you need. And I think true with virtual nursing and wanting to implement virtual nursing, there's an ROI to that too. And that's not something you
Absolutely.
learn in nursing school, and when you're you become a nurse leader or anything like that. So let's speak the same language.
Yeah, yeah. And then this is really truly transformational. And I 100% know that we will get to a place where every room has virtual care and a camera, microphone, speaker in every room. And that's part of the infrastructure of the room, almost like oxygen in the wall.
Hmm.
You're going to
Yeah.
need a virtual care in every room. And so, why should nursing shoulder the 100% ROI for something that is infrastructure? So, I think that's
That's right.
also a paradigm shift about the
Hmm.
ROI. So, I got like a little mad. I was on a panel and someone said like nurses don't know how to do an ROI or business case for virtual care, and I'm like, why is it all on our shoulders? Because it's
Yeah.
way broader than that. And then we do also offer, so we have the time and we have the kind of the resources to help with some of those pieces. So
Hmm.
really, I want to encourage anyone to reach out to your AvaSure team because we've already kind of done the homework and can give you some of the pieces so you don't have to start and reinvent the wheel on ROI. So, Claire, thank you so much for your time
You're
and just like
welcome.
with aplomb, just like dealing with a little bit of audio issue earlier on. And
Sorry about that.
it's just like it happens. And I just wanted to, I mentioned Elizabeth Gunn is doing a webinar with us. I believe there's a slide for that on July 31st. And she will be presenting along with Aaron Murray, who is their Chief Digital and Information Officer, who just happens to be getting his PhD in AI right now. So I'm really
Hmm.
excited about this webinar coming up on July 31st. So kind of an IT and clinical, and there are some people who really understand it. And then we have our symposium coming back again. So Grand Rapids is a fabulous place to visit. And so please put this on your calendars and come and visit us. Last year we had 25 different hospitals that were presenting on their virtual care. So we really want to create just a platform and a venue for you all to learn from each other, and then have some fun in between. So thank you so much. And thank you so much, Claire.
Thank you. It was great.